women voters. And we do have a very exciting upcoming programs that most immediately, April 19th, when we will have Commander Kim Bowser of District 6 and Lieutenant Michelle Fulmore, Director of the Training Academy for the DPD. We do want to make a point that we have, that there will be registration required of that meeting, but we're really looking forward to their presentation as the second half of the briefings that the public safety group has put together to share some of the many people, share the experience of many of the people that we've met with over this past year. Tonight briefing being the first, followed by our briefing on April 19th. And then on May 14th, our annual meeting will be held again this year on Zoom. And we have as our speaker, Dr. Dawn Davenport, who will be speaking about mental health concerns in Denver on behalf of families and children, and what are the greatest unmet needs, and perhaps what thoughts there are about requesting the new federal and state funding that's been made available and announced in the last 6 weeks. So we really hope you'll be able to join us. And then lastly, on the agenda, immediate agenda, is our legislative update with our lobbyist, the League's lobbyist, Andrea Wilkins, on May 24th. Pearl Ann just shared with you the Denver League's Denver League's position on criminal justice, which has been the primary basis on which we've been investigating the public safety, the members of the Denver study group. But I was able to dig deep over the weekend and discover that the position the Colorado League has regarding behavioral health is really relevant to our briefing this evening. And only going to point out that behavioral health is a position that the Colorado League took the initiative on back in 2015 and led to the addition of behavioral health to the U.S. Positions as well. Most specifically, effective reentry planning and follow-up for people released from both behavioral health hospitalization and the criminal justice system. So our Denver League has been right there at the forefront in advocating for the kinds of activities that we're going to be talking about tonight. So if you could change the slide again, Andrea. So our speakers this evening are Chris Richardson, who is a licensed clinical social worker. And
you're on mute, Barbara. Barbara, you need to, there you go.
Okay, sorry. I hope that just happened.
Sorry, I think I might have done it, Andrew. I was trying to mute some people and I might have gotten you too, Barbara, so sorry.
Oh, no problem. Chris is the lead staff person at the Mental Health Center of Denver, working in all of their criminal justice programs there. most particularly the co-responder program, which she's going to be speaking about, as well as the staffing for the STAR program. So the public safety group did have an opportunity to meet with Chris, and were really kind of astonished at how much the Mental Health Center of Denver is doing in this area. So we really appreciate Chris leaving the dinner table, coming downstairs and sharing his thoughts with us. And Carly Sailon has spoken to the Colorado League at the legislative training in January about the STAR program, and the membership there was so impressed that we really wanted her to come again and talk about all that is happening with the STAR program. And I'll let her describe it, but it's very exciting and a national model as well as a co-responder program. So I've asked, Chris and Carly have years of experience working with one another, including speaking to groups. So I've asked them to share with us that same camaraderie that they have shared across the years as they make their presentation. But thank you very much to both of you for being here.
Barbara, and I want to clarify, before I met Carly, I had dark hair, and then I met Carly, had to work with her, gone straight silver since.
That's true, but he has a lot of successful programs that he oversees that I built, so he's doing just fine, right? As you can see, Chris and I have quite a rapport. We worked together for 6 or 7 years at the Mental Health Center of Denver, in the criminal justice space, and overseeing several programs in the jails, the courts, law enforcement partnership program. So if we poke fun at each other a little bit, or bring some of that humor into this meeting, you'll know where it came from.
Yeah, and I think we always like to start kind of like our conversation of how we got here, and what that looked like. Carly and I started with the Mental Health Center of Denver as a sort of community treatment case managers. High acuity individuals with behavioral health needs, historically coming in and out of jails, coming in and out of the hospitals. And really working with those individuals and giving kind of that support and recognition to them that they have talents and skills that we can help kind of build upon to really kind of show what recovery means to them. And I think in 2016 is when we first started this idea of how do we partner with kind of that the first responders. We actually just hit our 6-year anniversary with our co-responder program. Funny enough, it started on April Fool's Day when we showed up to the Denver Police Department and said, "We are your new partners," which it's fine. It's ironic now. But it was kind of that first discussion of, hey, how can we actually help people that are on the front end of crisis consistently and not wait for them to be referred by jails or referred by hospitals, but instead really see if we can help engage those individuals to get to those right services in the moment, and really provide a different lens attached to how you respond to 911. And we, Carly and I set that up as like, it really was a force multiplier with police. It was giving them a tool that they otherwise didn't have, giving them a system that they don't understand or don't know how to navigate the way we do, and letting them be part of that process of how do we support the community in a different way. And so we started our co-responder program with 4 individuals and kind of built that out to what it is now, which is roughly 36 on a 24/7 model. So citywide, and still being able to respond to those crises. And that's kind of where Carly wandered into the world of, why are we doing one way of doing things all the time? I'll let her kind of.
Sure. So what we realized, so you put a bunch of social workers in a police car, and that's great, and they were helpful, and DPD was great partners with us and really bought in to having this additional resource quickly, and quickly saw our value being in the cars with them and being present on these scenes. But when you give a bunch of social workers a police radio, you become a social worker for two reasons. One, that you want to help people, and two, because you're kind of nosy. So you start listening to all of the chatter coming across the radio, and an eye-opening experience for me was really listening and hearing all of the different reasons that folks call into 911 communication. So you have those emergent medical issues that require EMS. You have those issues that require a firefighter, and you have those public safety needs that require police officers. But then there's also this whole other subset of calls, folks calling in because they need a connection to a resource, a food bank. They took the bus from Philly to Denver and they ran out of money, and now they're stranded here and they don't know what to do. So there were all these other calls that our co-responders were going to and were handling appropriately, but the officer wasn't needed. And we really started thinking about creating a menu of options in Denver for folks when they call 911 and need assistance. So we have our three traditional response models of police, fire, and EMS that have historically handled all of those calls. Then we added the co-responder program, and we really saw, okay, co-responders with a police officer should be showing up on calls where we need that clinician there for some sort of behavioral health component or de-escalation component, but the officer's with them because there's some sort of risk. It's a higher acuity call, there's a weapon present, there's some sort of scene safety component where we're sending officer and clinician together. So what else could we create that sort of fills this gap of all these resource requests, assistance calls, these low-level calls that don't require that officer there? And that really got Chris and I thinking about, creating a menu of options and what additional programs we could put in place to meet all the needs of the community, versus kind of being in this traditional model of, well, we have to send some sort of emergent response, maybe with a clinician, maybe without. And I was actually doing a podcast years and years and years ago called CityCast Denver. And someone asked me if I had ever heard of the Cahoots model, and if we were interested in bringing that to Denver. I had never heard of the Cahoots model. So I asked her for some education on it. She told me. I looked up the Whitebird Clinic and cold called them the following day and said, hey, we're doing this kind of co-responder work in Denver. What are you guys doing out there? And they told us that they were pairing a crisis worker with an EMT basic, and that that team was being dispatched directly through 911 communications to low risk, low acuity calls. So that really kind of got Chris and I's wheels turning about this would be a really great addition. And we should really be looking into this. Fast forward a couple months later, I guess, Chris, and there was also some push for the community that DPD should be looking at adding this civilian type model. And May of 2019, a pretty large delegation from Denver, including Chris and myself and some community advocates and city stakeholders, went out and did a site visit to Cahoots and learned a ton from them. And that really solidified, I think, in our minds, this would be a really easy lift for us. We're kind of in a lot of ways doing this type of work already, and we're just sort of changing the players.
Yeah, and so luckily we had Caring for Denver that were able to help fund our initial pilot. We were able to do it with pretty kind of stealing resources that were already in existence so that we could get this off the ground quickly. We had a minor thing called the pandemic that took place right when we were trying to kick off. So we had to hold for about two months, probably 3 months, but we kind of recognized that we were seeing 911 calls go up a lot more for stress, anxiety, social isolation, things that were normal or no longer normal. And we decided we needed to lean into, we needed to help the community. We needed to be able to go and see them. So we started June 1st, and we really didn't look back. We were able to really respond to 911 keying up immediately and saying, hey, star one, go to this location, and being able to help wherever we could. And I think within that first 6 months, we really showed a successful program of what could be. The mayor went ahead and said, here is a set amount of money to be able to help expand. Caring for Denver matched that. And right now we're kind of in the middle of a tailor end of the expansion piece to be able to have that, where it's not just the pilot in the downtown corridor area, but instead responding to everywhere in the city of Denver. Hopefully, in a perfect world, having 5 vans. You guys happen to have big, awesome vans sitting somewhere that you're not using, we would totally take them off your hands. Yeah, we're definitely going up to that expansion of being able to respond to everyone in the community that needs it and getting the message out to them.
Yeah, so in the pilot, we ran one team, so a clinician and a medic from Mental Health Center of Denver and Denver Health in our downtown area, Police District 6, Monday through Friday between the hours of 10 a.m. and 6 p.m. Our citywide expansion is currently working up to 10 teams and 6 vans responding citywide between the hours of 6 a.m. and 10 p.m., which we've identified at 911 as our highest call volume time. So we want to put our initial wave of expansion resources there first. Our 3 most common calls are trespass, unwanted party, welfare check, and behavioral health crisis. So low-level, non-emergent behavioral health crises where folks are safe enough to wait for the START van to get there, because much to my chagrin, they never let us run any lights or have sirens or anything to drive code 10. So still working on it, personal goal, but they said no. So, and Chris has seen me drive, so. So to date, we've run just over 3,300 calls for service that would have otherwise been dispatched to police. And we haven't had to call for police backup due to a safety issue on any of those calls. The way that our call is triaged to STAR, you can call police non-emergency or 911, or we have a STAR line that's answered out of Denver 911 as well by our civilian call takers, and that's 720-913-STAR. So the call taker answers the phone and they're asking the same questions that they would for any 911 call. They're all screened the same. They ask you what your location is. They ask you, is anyone hurt or injured? They're asking for the presence of a weapon. They're asking questions around time sensitivity. Do we need to send a lights and sirens response, or is this a more non-emergent call? And they're asking questions about public safety. Has a crime been committed? Is there a suspect or a victim? If all of those answers are no, then our call takers can start thinking about STAR as a potential option. And if this is something that police need to go to, or a co-responder unit, or a fire truck, or a non-emergent ambulance, or whatever it might be, or is this more appropriate for our clinician medic team? And we can handle an array of issues on scene. So the clinician sort of takes all the behavioral health crisis stuff, de-escalation, support, resource referral, all those things. And our medic can talk to folks about, low-level medical assessment and triage. A lot of the folks that we come in contact with have a lot of barriers to accessing ongoing treatment. They may be getting a lot of their treatment for chronic health issues in the ER, and not really engaging in that ongoing care. So the medic can work with them on a more appropriate level of care and those ongoing supports and resources. So we really see STAR as a 2-prong approach. We have the clinician medic team that show up, that sort of mitigate whatever, issue is going on and get an understanding of what's going on. And then we very heavily rely on our community partners and agencies to then do that warm handoff to and connect folks to those ongoing supports and services. So we really have our bases covered along the continuum of physical and behavioral health. Oh, hold on, Chris is on mute. We get muted.
It really is about how someone is engaged as well. I think what we hire specifically for are individuals that are really nimble with being able to build relationships and being able to talk with people about what. It's one of those things, like in a crisis situation, like we can handle crisis, we can kind of make, where can we get you to make you feel safe? But the reality is the outcomes that have to come next are even more important. It's how do we get you support in the community, whatever that is you're saying you are looking for, to really be able to keep you connected to those individuals when you're not doing well, to be able to talk through some of whatever is going on. And hopefully 911 doesn't become the go-to for like how to treat it. And so we're really working with our clinicians and building relationships in the community to make sure that whatever someone's requesting, whether that's mental health, whether that's substance use, whether that's safe places to be that aren't a shelter, or a safe place to be that is a shelter, or anything that really is, hey, I've wanted to do this and I'm ready to take that vulnerability step, and being able to help facilitate that. And part of that is community partnerships and really working with how do we do this as a community and a social net to help people out and kind of build on that recovery that they're looking for.
Yeah, and oftentimes, sometimes we contact folks and it is a formal treatment referral that's required. And sometimes we contact folks and they just need support and someone who's going to show up from kind of a non-judgmental point of view and listen to them. And sometimes people just need the supplies that we carry on the van, which include, socks and feminine hygiene products and sweatpants and sweatshirts and hand warmers in the winter and those sorts of things. So really there's no typical day on STAR. You're constantly coming across new situations and having to creatively problem solve, and our staff do a great job in this type of clinical work. You don't have the luxury of 4 to 6 sessions in an office to build rapport with your client. You have to do it in sometimes 4 to 6 minutes, and sometimes in an alley, and sometimes on the side of a highway or in a park. So it really requires, I think, a great deal of skill on the part of our clinicians to really be able to make that connection with folks and build that rapport and be able to get creative and really show up to work every day and never know what their day is going to look like, and take it in stride and make sure that the folks that we serve feel that they were supported and put in the driver's seat of their own solution, versus us showing up and telling them what we think the solution should be.
And then as far as the training that our guys get, I think this is an ever evolving process. So almost everybody on the van is currently licensed. So they come with a master's level education attached with behavioral health needs. We're constantly evolving of what it is that they need to know by what they're experiencing. So a lot of it is, trauma-informed care, motivational interviewing, crisis de-escalation, harm reduction, and then, the stuff that we don't think about as social workers that we're like, we probably need that. Like Carly helps us with radio training and helps us understand the 911 system that historically we don't know. DPD helps us understand this is our process when we do stuff. So if we collaborate, just so you're in the know, we have not had it yet, but it's not, we do get training on kind of scene safety. We are very good at spider sense of when things don't seem like they're right, to trust that, but also recognize like what happens when something really big happens. Where's the best way to be safe or go to? And officers help us just understand like different safety components attached to that. And then we really welcome community members to come in and talk to us specifically about what it is that their programs or organizations do, what they see as the best need, what they see as like how we can help. And then we invite them in to tell us. So we've had like Rocky Mountain Human Services come in, developmental disability organizations, age-related organizations. We had the center come and talk with our people and really help us inform from their perspective how we can be useful and what information is really important when their population is contacted by STAR. And it's nice because it's a mutual, that not only are we getting training, but we get to also talk to them of, well, if we have someone that would be great for your service, what do we need to do to access that? So it's kind of that two-way street where we're kind of building that net of how do we help support everything in the community through collaboration.
Yeah. And Chris kind of touched on something that I'll segue into. When these programs are discussed, the topic of safety always comes up. Well, how can we send, Chris is going to probably wrangle a child or a puppy. How can we send civilians to these calls coming into 911? Someone is inevitably going to, get hurt or something's going to go wrong. I would argue that this work is going on in communities already. Chris and I come from a community case management background. We were out in the city contacting our caseload for if they were unhoused at their encampment or in an alley or in Civic Center Park or in their home. We were transporting clients in our own vehicles, and no one knew where we were on a minute-to-minute basis like they do with dispatch. So actually, you know, the work that we do on STAR is very similar to the work that you do on an assertive community treatment team as a case manager, but you have the supportive dispatch that knows where you are and is tracking your location all the time, and a police radio where you can call for help if you need it. So I would argue that, you know, this work is safer with the supportive dispatch, and also recognizing that I think a lot of that comes from stigma, that folks that are popping up on the 911 system or folks that deal with behavioral health or substance use issues are inherently dangerous and unpredictable. And between Chris and I, we have contacted thousands of folks, you know, struggling in different ways, you know, and have really seen that if you show up and you are kind and supportive and non-judgmental and come from a place of wanting to help, that is very disarming in and of itself. And also, you know, recognizing that sometimes the behaviors that are associated with behavioral health crisis may be off-putting, but they're not necessarily dangerous. So Chris and I used to have a sign in our office that says angry and yelling does not mean violent or dangerous, because, you know, if STAR's showing up or co-responders are showing up, it's not a great day for someone in one way or another. I get angry, I might yell from time to time. That doesn't necessarily mean that someone is inherently violent or going to hurt me. That means that they're having a bad day and they're upset. So I think, you know, that's important in terms of thinking about safety.
And I think that's part of what makes this program so creative and imaginative. It's not just the response we're getting, but we also are informing a system of skills that can be used and kind of being able to inform the different ways that you can approach people. And Carly and I have probably heard a million times, well, this person's yelling. And it's like, yeah, it's a Tuesday. Everyone yells on a Tuesday. Like, it's literally like clients used to function. Like, I can be a sounding post for someone's frustration. It doesn't mean that they're actually angry at me. They're just frustrated. And that's no different than how everyone has in their life. And it's working with them to be just that sounding post until they get it out. And then it's redirecting it into a more positive space. And it's been pretty amazing to see the city kind of understand and transform to understand a little bit more of that. Like Carly said, they used to be really nervous about where we were and how we were doing it. And they're like, well, it's an alley in downtown Denver. And I'm like, Doug's alley? Like, let's go to see Doug. I mean, like, that is where we were at consistently. Like, those are our people. Those are the people we give voice to. So I think that's where we have the ability to kind of change the system from within to help them understand, you know, that not everything has to be viewed so scary, that it can be viewed more in a recovery lens, and giving people support really helps them move forward and feeling like they're connected.
And there's a few ways, another data point I think that's worth mentioning. There's a few ways that STAR makes it to calls. So our newest data shows that 75% of the time we are dispatched through 911 communications. About 15% of the time we are requested by DPD officers who show up on scene first, recognize that they aren't necessarily the right fit for the situation that they're coming across on that scene and requesting for STAR to come take over. Doesn't necessarily mean that our dispatch procedures aren't working well. It just means that sometimes the way that a call comes into 911 isn't what you find when you show up. You know, it might be third-party information that's not quite correct once you get there, but we really appreciate that partnership with DPD. And the rest of our calls are self-initiated response in the field, because as far as Chris and I are concerned, the best 911 call is the one that never happens. So if STAR sees someone having a big behavior outside Starbucks on the 16th Street Mall, you know, or sitting near City Park on a curb crying, STAR will hold themselves out and will address that and offer support.
And I think that I'm responding to the one about how did police view this kind of help. I will say that I think the journey with that has been pretty amazing. Denver's a pretty progressive moving. Chief Payson is one of the great visionaries when it comes to like, how do we not alienate, but collaborate and coordinate and recognize our shortcomings and build on those. And so when we start, when we were starting 6 years ago with police, it was a very awkward first date for a little bit. But once we overcame kind of like, hey, here's the skills I can bring to the table. Here's what I can do. Fast forward 6 years, like, I don't know that they would know what to do without a clinician available. And I think that actually allowed STAR to kind of take off with relative ease because they knew that clinicians have skill sets that can actually help them and coordinate with them. And I think that's what allowed us to help as well. And it is kind of that fun thing of when you ride with a police officer for 10 hours with co-responders, like you start talking to them, you develop trust and you develop relationships, and it starts turning into, hey, I trust you. This is how I'm feeling. Do you think I need help? And it's not just grunting and saying, I'll stuff this, it'll be fine. It's like, oh, I trust you. You're telling me, yeah, it's probably not the worst thing to talk with someone about. Okay, I'll go talk to someone. It's really breaking into that culture of, we don't need to talk about any issues, but instead, like, I have a safe person that I can actually bring feelings up to, and they can give me an honest take. And I trust that what they say is something that I should look into.
First of all, Chris, you're taking Pearl Ann's job. She's moderating questions from the chat at the end. Second of all, see, what does he do without me now on a daily basis? It's a little scary to think about it. But I will say I was actually in a meeting with a lieutenant a few weeks ago, maybe a month ago, and he was pretty honest, and he said, I didn't think this clinician program was going to last. I thought they were going to put a couple of you guys in the district and it would fizzle out, and I didn't put a lot of stock in it. And he actually said, he was like, we wouldn't be able to do our jobs without you guys at this point. So I appreciated his honesty. I wasn't offended. It's actually really great to hear that someone who kind of shrugged us off maybe at the beginning has become such a huge supporter of the program, and then really sees us as a great asset to the department. So that buy-in from DPD has been wonderful, and has really contributed to the success. I do a lot of meetings with other areas and jurisdictions who want to look at call response and or a STAR type model. And one of the consistent questions that I always get is, what kind of pushback did you get from your local police department? I think there's this assumption that we must have an adversarial relationship, and that, they probably don't like having us around. And they're kind of shocked to hear that, DPD was absolutely on board for the co-responder program and just bought in really quickly to STAR, and we don't have that adversarial relationship. The truth of the matter is, the officers on patrol every day in this city sort of recognize that these STAR calls and a lot of these behavioral health calls are sort of a mismatch, and feel ill-equipped showing up and trying to help people with a incomplete tool set, and really see the clinicians as being able to take that off their plate and provide the appropriate resource to the community. So that's been really wonderful to see. And we're really proud of the department that we have here in Denver and how progressive they are. Did we hit everything, Chris?
Well, no, and now I'm scared to answer any of the questions before.
No, you're not the moderator. Pearl Ann will moderate our questions.
It's all good. You can read them too, Chris.
He goes rogue sometimes. You gotta read them.
Well, let me know when you want me to do the questions. Happy to do it.
Yeah, I think we're probably ready, right?
Okay. Well, as was mentioned, Chris answered some of them in there. So there was a question about the number of 3,000 responses, what time period. And so it was from the start of the program.
Yeah,
right?
June 1st of 2020.
Right. And then citywide since January 1st, 2022, right?
Yeah.
Someone asked, what are your most common outcomes?
Oh, that's, there's so many different outcomes, and I'll let Chris, get more into the nitty gritty. But most, frequently we are referring folks to an array of community resources, including shelters, whether that be overnight shelters, day shelters, physical health clinics, behavioral health clinics, transporting folks. We do a lot of people moving around because sometimes that alone will solve a problem. But also there are tons of things that don't fit neatly into boxes that the clinicians do on a daily basis.
Yeah, I would say I think it's roughly 23% of our calls actually end up with individuals reconnecting or connecting with mental health services. We do, not sure if you're familiar with the Behavioral Health Solution Center, but it's definitely a amazing resource to be able to drop individuals that don't need to go to a hospital, but also we don't want to just say, bye, we're leaving you in the community, but it's like a voluntary option for people to deal with whatever's going on, but have therapeutic support 24/7 as they kind of work their way through the treatment team there and accessing services. But like Carly said, it's kind of one of those unique things. Like last week, we had a family that had 3 kids that we were just trying to say, well, we don't want you on the street. So what can we do? And calling in all our relationships that we had with host and the different, the makeshift safety shelters for families and stuff. And we're able to get that family into congregate housing through one of the motels, but then had one of our case managers actually follow up, and that person and the family actually got into long-term housing through a grant that they just established. So in a quick 911, we're concerned about a single parent with 3 kids. It turned into long-term stabilization for this family and hopefully next steps in there, whatever they need to do for that. So it's one of those weird pebble scenarios where just like the minorest of things can actually flourish into that. And we see a lot of that with the VA specifically, because a lot of our VA veterans that are transient, people are looking for them. Like they are trying to get those individuals housed, but it's hard to locate. And so when we do, we have the ability to tap into the VA and say, hey, we have this person, like, what can we do? And they're like, oh my gosh, we were looking for that person. Like, can you get into the VA right now? And I love those because we get to be the bearer of good news of, hey, you have housing. Can I get you somewhere? And that person usually is like, I was just not doing well. And now I just got good news like this. Yes, where you want to take me. So it really can be an earth-changing thing. And it really is all about relationships and being able to call someone in the moment and say, this is what I got. Where can I help this person out? And I think that's where we're hoping to continue to grow and develop. Because the more we can do that, the more it's not one-offs. It just becomes the norm of that social safety net that can really help the community with whatever comes up.
So it sounds like you do have facilities to take people. Is there enough of them for the short-term and long-term treatment? And if you could tell us more about the drop-in behavioral center, that sounds fascinating too.
Yeah, so the answer is no. And I would say it's more no as that we still have resource gaps. And I think STAR's in a position to be able to point those out and be able to voice those. We still don't have shelters that allow couples. We still don't have great shelters that allow pets. We don't have places that someone that says, I am addicted to heroin and now fentanyl, and I want to get off this in an inpatient setting that I could bring them to, and immediately they're off the streets and in a treatment center. And I think those are things that Denver is going to continue to have to look at growing and look at building to help support like those needs specifically that are being, I think the common one that Carly and I had that we're just like, we want it to happen as fast as it can. People that are homeless that can't take care of their basic needs, their ADLs, can't be at shelters, but also don't need to be in a hospital. But there's just no place for them. So we just see this revolving door of hospitals being that contact. So yeah, I think that's something that's going to be addressed, and I'm hoping we can shine lights on that as we need it. The Behavioral Health Solution Center is brand new. It's opened up in May last year. It is a walk-in crisis center, but it's only drop off for STAR and law enforcement. So it really is meant to be a resource for first responders. They can get dropped off on the first floor. It's a 24/7 triage, clinicians, doctor, just stabilization to see how someone's doing. And then if they need more, or if the crisis gets managed, they can go back home. They'll help facilitate that. But if they want a little bit more security and safety, they can actually go to the next floor, which is a 7-day crisis stabilization bed. They get their own room, still same thing. It's group check-ins, it's discussion about next plans, it's medication bridging. And then if they need something beyond that, which is more mental health treatment connection, they can move to the residential floor, which is a 30-day bed stay. So someone making it through that entire process can be up to like 40 some days. And the goal is to actually come up with solutions instead of band-aiding crisis, but actually getting people to the right place. And it's been amazing. Not only does STAR utilize it pretty frequently whenever possible, officers do as well. So really being able to hopefully grow those throughout the state. I'm really hoping this will be a model for it.
There's a couple of questions about data, which is my personal favorite thing. I'm a data person. Do you have data regarding the types of calls, and is it distributed back into the system as indicators where need is? And is anyone else looking at your data to create other social service needs for the city?
Yeah, so I think one of the things that we've quickly realized was that the work of STAR could be used to identify system gaps and inform where additional resources were needed. So we also just contracted with the Urban Institute to do a 2-year third-party evaluation that's going to highlight those system gaps, look at things like customer satisfaction, cost savings analysis, outcome data, all that sort of stuff. So we do have anecdotal and preliminary data that says we need this, but we're looking for, a really formal study that we could use to inform those system gaps. So for sure.
So there's a couple of questions on safety, which you might have answered. Do you go on calls where a weapon is identified? And so that's no, that's what I figured. And domestic violence calls can be volatile. Do you go on those calls, or how do the dispatchers decide if it requires a police officer or both of you?
For sure. So no weapons. We do not respond to domestic violence. That is a volatile situation. And it's also very important for the victim to have contact with an officer and a victim's advocate in those cases, because there are lots of protections available for the victims of direct domestic violence, things like being able to break your lease without penalty if you want to move out of a unit, where you've been the victim of domestic violence. While Chris and I, and our clinicians can de-escalate those situations and provide support, we're not experts in that legal arena, and we want to make sure that the victims of domestic violence have every opportunity to keep themselves safe, which is really best provided by the victims advocates that work with DPD and our dispatchers. So all of our call takers and police dispatchers at 911ers are civilians who are trained to do that work. And we've put them through several in-service trainings. We created a processing guide for STAR that shows decision trees that they can use to make their decisions. So that's what they use to triage calls to STAR. And then for our co-responders, those clinicians are in the car with the officers, and the dispatchers can see on the screen which officer has that clinician and if they're available, and can dispatch them to higher acuity calls with a weapon or a scene safety component.
Do the civilian dispatchers have a greater longevity than the police fire dispatchers? Apparently there's a higher burnout rate, was someone had heard.
Our police dispatchers are civilians. They are not sworn officers, and all of our call takers are civilians as well. It is a difficult job. Our call volume is very high. They are on the phone. Our call takers are back-to-back calls all day. Essentially, we take over 2 million calls at Denver 911 a year, so they are busy. Our police dispatchers are expert multitaskers. The things that they have to keep track of and do all at the same time blows my mind, and I fancy myself a pretty good multitasker. But they are civilian employees. We're combined communications. We have our universal call takers, our police dispatchers, our fire dispatchers, and our EMS dispatchers all under one roof, even though they do separate work. Our fire dispatchers are sworn firefighters. They're the only sworn employees in the building. And they don't really have a permanent staff. It's typically firefighters that are on light duty that come in while they're not able to work on the street, do the dispatch, and then return to the street once they're recovered. There's a few permanent characters, but most of them are on light duty. And then our EMS dispatch, they are civilians as well, and they are employed by Denver Health and Hospital Authority Paramedic Division.
Someone asked, you started downtown Denver. How has your experience with areas outside of downtown Denver been different than what you experienced with the beginning of it?
I think the biggest difference being more housed behavioral health. I think a lot of people assume that it's just downtown is where all the behavioral health happens. And I think a lot of hurting and quiet suffering happens when you are between four walls and don't have any way to actually get support or don't know how to access it. So we've definitely noticed an uptick in our housed individuals that we're going to see and how to be able to do that. We've noticed an uptick also in age-related. I think we're definitely seeing more and more people calling in welfare checks related to I haven't seen my mom or talked to her in a while or haven't seen her in a while, and being able to go to those. So yeah, it's definitely been unique and different, but enjoyable. Like that's the whole point, is like being able to go citywide and see the different areas of our city and what the needs are in those specific areas.
Chris, blink twice if you need help. Are your kids taking over here?
Don's next to me just like slamming things together.
That's great. So a couple of questions about the status of funding for the program, long-term picture, how far out is the funding assured? You had mentioned that Mayor Hancock has financially supported this work. Will a new administration change things?
I think that we are sort of poised to, see funding for this program continue. We have, overwhelming support throughout the Department of Safety, Department of Public Health, the mayor's office, city council, Caring for Denver. We're very lucky in that sense. I think, Chris and I, coming from community behavioral health, you're always figuring out how to do more with less, and funding is kind of consistently an issue. And we're now, involved in this program that has, not only support in general, but financial support behind it from the city. So things could always change administration to administration, or city council, members shift. But the truth is I think that the common ground that folks can always come back to on STAR is the work that's being done in the community and the folks who are being supported. And I don't think at this point we're worried about any sort of funding issues.
Well, that's good.
Yeah.
So suicide rates in Denver, what ages are you seeing upticks or the most?
Unfortunately, we are seeing an unfriendly trend of youth age 18 to 25 that we're seeing more of an uptick for. I think the 25 to 35 demographic is more individuals that we'll see probably once or twice, but I think it's our young youth that are actually struggling. And I don't know if I have to tell everyone on this call. I think we definitely prioritize funding adult-based programming throughout the state, but I think we need to really target the children-based programming as well. How do we prevent kids, or how do we have that conversation about mental health and mental wellness at a much younger age? Because I don't think we do it nearly as much justice as we do for adults.
It seems like particularly in the pandemic, young adults and teenagers are affected a lot. Are there places to take the 16-year-old, for instance, or do you get those kinds of calls too?
There's definitely not as much resources. The Mental Health Center of Denver, we have a specific youth-based drop-in individuals to help. We use Urban Peak a lot. We use a lot of family planning centers, really trying to rope in family as well, so that the kid just doesn't feel like it's their problem to solve, but it's more of a family dynamic thing. But there's definitely improvements we can make.
So we're getting close to the end of the questions. So for all the participants, if you have some that you want to push in, do it now. A couple of things. Yeah, Andrea Mitchell just put in advocacy, because that's what we always ask at the end. And I was going to ask that one too, is what can we do? But before we do that, do you see this becoming a norm on a national level?
Yeah, absolutely. I do, probably between 8 and 10 meetings a week with other areas looking to replicate this. Chris and I really believe in offering that information to other folks, paying it forward as Cahoots, did for us. I think, especially in the past God, what, 2 years time, we're sort of in a time warp with COVID, forgive me, with the events across the country and sort of the culture around policing and law enforcement. There's been a lot of push to say, let's do things differently. And I think 911 has a lot to do with it as well. If you look at 911, we're really one of the only industries that really hasn't changed at all in the past 70 or so years, which is, saying, well, this is the way we've always done it isn't always an appropriate answer. And I think it's time for some updating and shifting in that in our industry at 911 as well.
And I think our program, and I think what I love the most about Carly and I's relationship with it is I am a Colorado homer by nature. Like, I was born in Denver, like so proud of the city and the state that I live in to be able to like launch these type of programs with a lot of positivity and a lot of collaboration. And that is not shared across the nation. And I think that's where Carly and I really talk to communities where we're just like, your view on this is like going to have these kind of problems. And like, not that you need to replicate what Denver's doing, but there is that, like, maybe you're looking at it only one-sided, and maybe how do we help steer you in the other side to see the other side of the fence, and then bring that side to you. And then you can have like a collaborative approach. Because the one thing that we will say till we're blue in the face is these programs did not happen because we stood in front of police and law enforcement and first responders and said, you guys suck at this, we can do it better. That's not how you sell these. It's about, we're in this together to solve problems to what our community needs. And however that happens, we want to make sure that every tool and resource is available to every responder. And that's why we have co-responders that not only work with police, but they work with sheriff now, and they work with the fire department. And it really is giving tools and resources that don't exist, and making sure that other communities understand how important it is to extend olive branches, even when you may not want to be able to kind of do this collectively.
Yeah, and while Chris is a Colorado native, I was born and raised in New York, so we have very different perspectives. And while I love my home, it's great to be in Denver that really supports and embraces this type of work.
There's a couple of questions about different populations. Do you see any change in the needs of the trans and LGBTQ populations' needs, given the pressures from other states' laws? And are you accused of racism by anyone?
I'm not sure I understand the racism question. By folks we're serving, or could we get a little clarification on that? By who or in what circumstance? I mean, the answer is largely no, but I want to make sure I'm
Jeanette, do you want to unmute and ask? Because I was not sure either.
Yeah, and I felt the pressure of trying to write that. It's a lot of this came out of protesters who were protesting the racial abuse after George Foley was killed. And so I'm wondering, is this helping to reduce any racism also?
Well, I will say, we were working on this project long before the George Floyd protest. Denver was committed to, implementing these types of programs before public pressure really, came on to do so, which I think we're proud of. We did launch kind of right in the midst of all of that, but we had been working on this project alongside DPD for about a year prior. So this was kind of already in the mix. And we get asked a lot, does this make your community safer? Does this, I guess I'll just say, like, we don't have these programs because DPD is out there doing an awful job and being, racist and violent to people on a daily basis. We've just sort of historically tasked police with issues that are not law enforcement and public safety related. So it's more of a question of providing the right response than saying, DPD, you're dangerous and doing a bad job, and we can't have you responding to these types of calls.
So Carly, I know you have a stop at 6:30, so I want to, I'm sure.
Yes.
If I'd like a minute, do you have anything that we should do that we should advocate for, or as we go forward as league members?
I think, you know, honestly, like in your, if you were in Denver, we appreciate your support and, you know, educating people about the program. I think, you know, if you're statewide, you know, having these discussions in your community about what these models might look like. I will throw my email in the chat. I appreciate you guys having me tonight. I'm sorry I have another engagement with another community group at 7, but please feel free to reach out to me at any point with any questions or concerns or feedback. So thank you guys.
Thank you both. You're amazing. And we love what you're doing out in the community.
Thanks.
Thank you so much.
Thank you. I'll let
All
Chris
right.
wrap up a little bit at the end here if there's anything.
I was gonna say my biggest thing, especially for advocacy for the state level, is Denver was lucky enough to pass the Caring for Denver tax, and I think it would pass overwhelming, like 80%. Rural communities do not have the luxury of that sometimes. And I think when it comes to that question about like sustainability for funding, a lot of communities across that have co-responder programs that are thinking about STAR programs are not only having to worry about how do we build relationships, how do we do this work, but they're literally thinking year to year, how am I going to get funded consistently? Something Denver doesn't have to worry about. And I think that gives a lot of pressure off plate. So I know there is stuff in the legislation specifically about long-term funding and stuff like that. So I think that's my biggest advocacy, is pulling for communities that don't have metropolitan ability to make those happen, and really advocate that there are people that can benefit from these responses, benefit from the resources that are in rural communities. And it's just, how do we help supply those communities with funding that's sustainable?
Yeah, that's great. Thank you. We're close to the end of the questions. Any more that people might have? Kathy, I see a finger up.
Yep, I just had that question. What are the obstacles that you face in trying to expand the program? I've heard that there are just some basic logistics, but what obstacles get in your way in expanding the program?
I think right now the biggest obstacle is the employment availability. Like I think every organization throughout the entire world right now is like, we just can't find bodies. So I think it's finding the right people, because this requires the right kind of person applying. And we're just seeing that like they trickle in every once in a while and they're amazing, but it's not like it once was, where it was like we had 15 people that we could really decipher who's the best person. So that's one. If I would have known about supply chain issues, I would have ordered the vans about 5 years ago. But the van, like, they said they're going to be here April 1st, and now it's looking at like August, and I'm willing to bet it's more 2023. It's just supply chain issues. Like, we just can't get vehicles. So we're band-aiding with vehicles we're currently using, but the ones that are like really STAR vans, we still haven't had those. So that's a problem. And I think when we expanded citywide, it was District 6 dispatchers at 911, like they learned over a year how to utilize us. And then when we expanded citywide, it was like 5 other dispatchers that were like, wait, what am I supposed to do with these guys? Like, what are they doing? And so January was a slow start, because then we also had the new variant of COVID. So it was like inconsistencies. And then, but last March, I don't know if Carly mentioned it, but we were on almost 500 calls. Like, that was by far the most efficient month we've ever had with 3 vans. So I think they had to learn how to utilize us and how to dispatch us. So I think as we, it is a learning curve with that. And then I think the biggest one that we've yet to decipher is when someone in way South Denver or Montbello or the west side of town says, hey, I need this kind of service. How do you give it to them in their community? Like, what providers are available in their neighborhood that we can connect them with that can do that, where it's not, you have to go downtown where all the services are. Because I think that's unrealistic for communities, that travel can be a barrier, distance can be a barrier. And quite honestly, like, I don't want to see my doctor that's an hour away if I had to take a bus. Like, that's just not feasible for me to do that. So I think it's being able to build those partnerships with other clinics and opportunities throughout the city and kind of give them a platform to say, this is what we do well, and this is how we want to be able to help.
Barbara?
Chris, I would like it if your kids can last another few minutes, uh, if you'd explain or describe a scenario that's more about the co-responder and how that works on site.
Yeah, I think the co-responder one's a very unique one because we built out kind of initially it was just go to mental health calls with officers, and we've expanded our expertise. Like, we were on one last night. We were just talking about it in our team meeting that one of our clinicians went because a individual was holding his dad at knife point. This was an individual with schizophrenia. He was 19, having his first psychotic break, had a lot of paranoia about his dad and what he was doing. So they sent officers and a co-responder, and it was kind of identified as like almost like a barricade situation, like a hostage situation. And it was the clinician that was able to really go in there, talk with the kid. He had the knife on him, and it was like, hey, we want to get you help. We want to be safe. Like, I'm taking off my radio so that you're not worried about me doing anything. Like, I just want to have a conversation. And the conversation is about how do we help you? And part of that is you putting the knife down and me doing that. And like, in those situations, like this possibly could have ended with this kid either getting hurt, dad getting hurt, or quite honestly ending with jail. And it all ended with him actually going to the hospital. And then we had our case managers following up today to get him into one of the programs that's first psychotic break, the Phoenix program for youth, and being able to really get him started on a road to recovery that is not just consistent psychotic breaks over a long period of time that can lead to criminal justice involvement into jail, but instead actually treatment on the very front side of this. And everyone was able to go home safe. Everyone was able to get connected with the right places, and it ended really positively. And that's kind of what our co-responder goes on. Those higher acuity ones where you can still have that clinical presence and that relationship and recognition that you are not a law enforcement with a badge, but you're with them for support and being able to do that safely and makes people feel comfortable. And those guys are really amazing with how they build rapport with individuals that are not doing well in the moment.
Thank you for, that was about as intensive example as I could have asked.
It was this morning, and it's so funny though, because it's like one of those, like, it's a perfect example of like high stress situation that ended positively. And we had our clinician in with a bunch of other co-responders and social workers, and he's just like quasi in tears, and he's just like, this impacted me a lot. Like, and he's like, I'm not trying to be like like police that stereotypical stuff this, but like, it's nice to be around people that understand what I just went through and how I can get there, and talking about like, I know now that I can like if I didn't want to work today, you guys would be okay with that. And we're like, yeah, like 100%. But he's like, but I also don't want to stay at home because I know the people that support me are here now and I can do that work. And it was kind of that therapeutic, like, you're in a safe space and thank you for being brave with your feelings attached with it, that we're hoping we can replicate with officers as well, where they don't feel they have to stuff everything. Oh, thank you, buddy. But it was just kind of one of those really real situations that was pretty impactful and pretty amazing. So
it feels like you need to go hang out with your family. Thank you so much, Chris. It was an amazing job you and Carly did. Thank you so much. And thanks to all of the attendees for the great questions. And if you're not a member, please consider joining. We'd love to have you.
Thanks,
All
everybody.
right. Thank you. Bye-bye.
Thank you very much.